welcome everyone who's here to another session of our BrainForward Echo series. I'm really excited to get to our speaker today. I'm going to briefly give an introduction for Dr. Santiago-Delgado. I know many members of the department, I'm sure, already know you very well, but for members of our program outside of the department, for those outside of UTMB, I'll just tell them a little bit about you. So you're a member of our Department of Family Medicine. Dr. Santiago-Delgado did her undergraduate at the University of Puerto Rico, where I believe she graduated magna cum laude. She did her MD at Ponce Health Sciences University, where she won awards in the Department of Family Medicine, as well as a Clinical Distinction Award. She did her residency here at UTMB in Family Medicine, where she's won several awards for her residency activities, her teaching, and her clinical skills. Her expertise is in diverse areas, but I've noted quite a few lectures and publications in the areas of women's health, which is why we're so excited to hear her talk today about peripartum depression, give us her insights on that domain. So as a reminder, we're going to give her time to present her talk today, and then after that, we're going to open it up so that people can ask questions or request clarifications if they want. That can be done through the chat. If people want, they could write a question and I'll bring it up later, or they can just chime in. We're also very open if people have cases that are relevant to this case or just relevant to our program in general that they want to discuss. They are welcome to bring those up. And just a reminder, if you do that, we are recording activities. We don't post any of the case discussions online, but PHI should not be present. So with that, I'll turn it over. Thank you for joining us today.
Hello, everyone. Thank you for the great introduction. So peripartum depression, and I will start with this picture. So when we see this picture, right, we see a network that's interconnected, and we see, whenever I see this, I look at support, which I think is very important during pregnancy and the postpartum period, right? So it's not just the mom or the dad or the baby, it's actually us physicians, it's their family, it's everyone that's around that new family, right? And this is the same for the first baby or the second baby. So that's why I like this picture, because this like really summarizes what is like the peripartum depression, where we will discuss later. So actually peripartum includes both during pregnancy and postpartum after pregnancy, because they're very tied to each other. So we'll discuss like both of them at the same time. See if I can. This. Okay, so what are our objectives? So the first one is to identify risk factors for peripartum depression, right? That's the most important thing. How are we going to screen? How are we going to treat? Who should we screening, right? Risk factors are very, very important. Then we will review the screening tools that aid in this diagnosis, and we will talk about the 3 principal tools that we have. And then at the end, we will talk about the management and the treatment during pregnancy and also the postpartum period. So this is summarizing our objectives for today. So peripartum depression, it's more common than we think. It occurs in up to 1 in 7 women. That is a huge amount if we think of it, right? How many, for example, on Mondays I'm in labor and delivery, and we have like maybe 20 to like 25 laboring patients, sometimes 21, right? So out of 21, that tells me that almost 3 of them will have peripartum depression. So that's huge, right? Why do we study this and treat it? It is because it is associated with a significant neonatal morbidity. So it's very important for us to catch this and treat it on time, not just for the mom's sake, but also for the baby. We've seen babies with moms that have postpartum and peripartum depression, they have failure to thrive. They don't gain weight as well. They usually don't complete their milestones. It's babies that they take longer to roll over, or they don't have a social smile. They have things like that. So when we as physicians see them in clinic, we don't see a happy baby. We don't see a baby that's actually thriving. There's also attachment disorders. These are babies that instead of showing the 6 to 9 month separation anxiety, we start seeing separation anxiety early on in a newborn phase, where that usually doesn't arise. And again, we also see developmental delay mostly at 1 year of age. That 12-month well child check, our residents know, is very important. That's when the baby changes from an infant to a toddler. And there's a lot of milestones that need to be completed. And these babies with moms with untreated depression usually have a lot of developmental delays, not only in the social aspect, but on the gross motor, and the fine motor and language and all of these other areas that we look for. So what about the mom, right? So peripartum depression, again, both during pregnancy and after pregnancy, is also associated with maternal morbidity. And of course, this includes decreased energy, concentration, sleep disturbances, and it also disrupts this maternal infant bonding, which is actually what the papers show is the cause of the developmental delay in the baby, right? And also like the healthy family dynamics. And when we look at all these symptoms, right, decreased energy, poor concentration, sleep disturbances, we think back of our CIGI caps, right, or our mnemonic to, rule out depression, because it is a depression, just like DSM-5, it's under the MDD category. And one something that actually I had to put in my presentation, because when I was reading about it, it really surprised me, is that maternal suicide is a more common cause of peripartum mortality than postpartum hemorrhage or hypertensive disorders. And this is huge. Why? Because again, thinking of my L&D days, I would say that out of 25 laboring women, 5 of them will have postpartum hemorrhage. And the hypertensive disorder we treat all the time. So maternal suicide being a more common cause than the mortality with these two things that are seen so often, it's a huge red flags for us physicians, and something that can't be overseen. What are some of the risk factors, right? So in medical school, we'll learn that the biggest risk factor for anything is a prior history, right? So history of depression on the mom, right? That's why it's so important when we have that initial obstetric visit that we ask all of these questions, not just genetic disorders, right? We're worried about diabetes, hypertension, Down syndromes, Tay-Sachs, but we also have to ask about depression. We have to ask about substance abuse. We have to ask these difficult questions that sometimes we don't want to ask, but will actually change our management and our treatment of these moms, right? The other thing is fear or childbirth or a traumatic birth experience, right? We have moms that everything is going well, and then the baby suddenly doesn't look good on the monitor, and we have to rush them back to the OR, and they have an emergency C-section, and they're intubated, and they wake up the next day. They haven't had that skin-to-skin minutes with the baby after the baby's born. So it is a traumatic birth experience. Also, the moms that are having babies after domestic violence or after being sexually abused can also have a higher risk of depression. Tobacco use is also linked to it, again, because of substance use. An adolescent's mom, right? Her life changes. She doesn't know what she's going to do, right? A baby's for forever. Single status, again, we go back to that first image of our support system, our network. We need support. A lower socioeconomic status because babies are expensive, or how am I going to afford formula? We have a lot of, and I know Dr. Alicea right now, she's in PD inpatient. We've seen a lot of babies come into our pediatric service because of hyponatremia or which is low sodium or low potassium. And it's because the moms tell us, I can't afford to feed my baby. So what I do is I only do 1 scoop of formula for 8 ounces of water, when it's usually 1 scoop for 2 ounces, because the mom really tries to make sure that that formula lasts, right? So all of these things are definitely risk factors for developing depression and anxiety as well. So 40 years old or older, right, which is called like advanced maternal age, domestic violence, like I had explained, maternal anxiety as well, and unintended pregnancy, and gestational diabetes mellitus, because of the future risk factors. And also during the pregnancy, our GDM moms are usually monitored closely. They have more visits. Some of them are afraid of having like a 10-pound baby. So that also comes with fears and anxiety that develop all through the birth experience. So these are some of the risk factors. And these are what we have to screen our patients for on that initial obstetric visit. So it's very important to distinguish peripartum depression from baby blues, because the prevalence of baby blues is 80%. So that's a huge amount, right? Out of 10 moms, 8 of them will get baby blues. But we have to make sure that we know what makes each one of them different, right? So usually the baby blues, they only that last a few days. So in there it says 10 days or less. Usually I see them like a week or less. It usually happens within 2 to 3 days of the mom giving birth. And the number one reason is like that sudden drop in hormones, and also like the new status of that mom. So it's also more like a situational problem. That's why it happens so fast. Again, I said at 8 out of 10, you have mild dysfunction that comes with having a newborn, right? You can't sleep, you don't eat well, you either shower or eat. And most important of all, there's no suicidal ideation. That mom tells you, I'm tired, I'm exhausted, I can't see the next day already arriving, but I don't want to harm myself, I don't want to harm my baby. For peripartum depression, just like the DSM-5 tells us about major depressive disorder, mom has to have more than 2 weeks of symptoms. That is very, very important. It can't be a few days. It usually happens within the first month. Again, this is not necessarily linked to a sudden decrease in hormones like the blues. This is more so a lot of traumatic events and a lot of things like flourishing up. That's why it happens during the first month, but it can actually happen within the first year. So we have to keep an eye on that mom. In family medicine, we deliver the baby, we take care of the baby and the mom. So we do have that continuity of care of, you know, monitoring and treating the baby every month so we can see the mom often. But if it's like, for example, an OB and a pediatrician, and you deliver the baby, you see the mom, and then you don't see them in a year, you might miss these peripartum depressions. And that's when us PCPs, when the mom comes back to us, then we diagnose. Prevalence, again, is 5 to 7%. There is a dysfunction, moderate to severe, right? It's like everybody says, a little bit of anxiety gets you going. But when you have a lot of anxiety and it's not letting you complete your activities of daily living, and it's really causing a dysfunction, that's when we have to treat. And the suicidal ideations might be present. So screening, what do we do? So in every prenatal appointment, we have to ask the PHQ-2, right? Which is those 2 very simple questions. Have you been down? Have you had loss of interest? We already all know them. If those are positive, then we have to ask a PHQ-9. That's the way to go. And this is prenatal appointments. All of them should have this. And this is actually a category A. And there's a table that I'll show you guys afterwards. In the postpartum appointments, right? Mom had delivered already. We're seeing her. We have the Edinburgh scale, which is the most common one. We can still use the PHQ-2 and then the PHQ-9. And we also have the postpartum depression screening scale, which I will explain the 3 of them later. And also very important, right? depression doesn't come by itself. We have to make sure that these moms don't have bipolar disorder or that they don't have postpartum psychosis, right? Which is this mom that we see in the news that drowned all of her babies and then killed herself, right? And of course, we have to assess suicide risk. And it's very, very important that if she tells you, I'm hearing voices, or I am thinking of harming my baby, we have to admit that mom for, of course, the mom's health and the baby's health as well. And we will discuss this in management a little bit further down. So these are the screening test tables, right? So the Edinburgh Postnatal Depression Scale, we have it here in the department. We have them in all the clinics, and it's a paper, and we'll show it to you later. It's 10 items. The scoring is a little bit different because we have to give numbers, and then towards the end, you like sum all the numbers. It's very quick, it's very easy, it's free, right? That's really good. So it's something that we can download, we can give to the mom. When do we do this? Usually at the 2-week well child check of the baby, we give this to mom. At the 2-day well child check, we can also give this to mom. And then when mom comes to us at that 4-week follow-up, or if she had a C-section, a 2-week, and that 6-week follow-up, we also give them this. So all of these visits that the mom has right after delivering, we have to give them this depression scale. The PHQ-9, it's all good throughout, like all ages, right? So, and we know pretty well that one. The postpartum depression screening scale was actually made for postpartum depression, but it is costly, right? It's $100. It's not easy. It's not free, so it's harder to have access to it. And if we compare the sensitivity and the specificity of both tests, we can see that the Edinburgh has a 75 to 100, the postpartum depression screening scale 91 to 94, and the specificity 76 to 97 versus 72 to 98. So if we're really, just looking for something free and easy, the Edinburgh postnatal depression scale is the way to go. And that would be our gold standard for screening peripartum depression. So how do we prevent, right? Medicine, and I love this, right? We're moving from let's treat the illness to how do we prevent the illness, right? That's what modern medicine is looking out for. So it's again risk factors, right? It's knowing who is more at risk for developing this depression. And there's a list in here, right? Like first-time mothers. I have a 9-month-old baby. Your life changes. Adolescent mothers. And mothers who have experienced a traumatic delivery, like I explained, postpartum hemorrhage, or they were going in for a natural birth and they ended up having a C-section or fetal death. All of these things are definitely risk factors. And actually, and this is what this article that it's in my references by the AAFP is an amazing article. This was one of the things that they actually discovered in the last decade that changed, is that there is a benefit from home health visits. Why? Because you're going towards the mom's home, right? She's not coming to you, you are going to her. So they were actually saying that physicians and providers could actually see a better improvement when they had home health visits than when the mom came in. Just because getting ready with a 2-day-old baby and driving to your pediatrician is not easy. So your pediatrician or family medicine physician going to you is great. You can also see their fridge, you can see their pantry, you can see how the house is doing, if the baby has, a crib, all of these things. Also, they recommended telephone-based peer support. So this is for the moms that need weekly visits and they can't come in. It's very good to just do a televisit with them. You can put on the video, make sure that mom is doing all right. We can see a lot from just someone's, physical appearance, right? And also psychotherapy to prevent peripartum depression. And this is very important, right? Because for mild and moderate depression, psychotherapy is the gold standard, is the #1 treatment. Whenever we see moderate to severe and it's affecting mom's life, we have to do psychotherapy, which the #1 is CBT, cognitive behavioral therapy, in addition to pharmacotherapy, which we will discuss. We cannot just say, yeah, it will improve once your hormones go back to normal. We have to treat these moms. So management and treatment. So like I explained, psychotherapy alone is actually considered the first line treatment, but only for mild to moderate. But if we have a severe patient, we have to start psychotherapy with medication. And I'll explain actually, and I'll list which medications are FDA approved. And then as I explained, CBT is the preferred type of therapy for peripartum depression. So it's very important for us to find a therapist that knows about CBT. This is not a one-time visit. This is a lifelong thing. So we have to find someone and also explain to the patient what the therapy is about as well. So the pharmacotherapy. So in pregnancy, the 3 medications that have actually been studied, and there was this huge case. Well, it was actually a clinical-based trial, and they saw that citalopram, escitalopram, and sertraline were the 3 best medications during pregnancy because they were monitoring the babies. They monitored the baby after the baby was born up with irritability and things like that, and these medications had the less side effects. Again, these weren't moms that were like not giving medication. These were moms that were already taking it and they just like saw how they were developing. For postpartum, it changes, and this is based on the transfer into breast milk. So it's very important for us to ask the mom, are you breastfeeding? Because if they're not breastfeeding, then we can continue using the same medications. Fluvoxamine, paroxetine, which is Paxil, and sertraline were the best ones since they had the less transfer into breast milk. Something very important is when the mom is pregnant, we usually start at double the dose. So the sertraline, instead of starting it at 25, we started at 50. And this is because the blood volume, right, that the mom has doubled. So her cardiac output, you know, we have more volume of blood, so we have to increase the dose. This is the complete opposite with postpartum. We actually start at half the dose. So instead of 25 milligram, we actually start at 12.5, for example, with sertraline. So this is very important to keep in mind, right? And most important of all, if you have a mom that is taking a medication already prior to becoming pregnant, we keep her on that medication. If it's an SSRI or an SNRI, if it's an antipsychotic, she's bipolar, she's taking lithium, valproic acid, then those are high risk. Usually there's the obstetric psychiatry specialty, and they deal with those. But those are moms that need, of course, like closer follow-ups and monitoring because some of these medications are teratogenic. But for our SSRIs, SNRI patients, we don't change it. We keep them because the risk of them actually worsening during pregnancy and postpartum, if we stop this medication abruptly, is higher than the risk of them continuing with it. And that was all. That is my peripartum depression in a nutshell. So these are the references. I have the articles in here. They are amazing. They summarize really good a very, very broad subject. And they talk about prevention and screening and how to treat, and they have all the reference to the clinical trials that actually showed the benefits of the SSRIs and the SNRIs. So I hope you all have enjoyed my short presentation, and if you have any questions, please